morning's panel series will be a discussion on the state of healthcare in Niagara region, and I'm pleased to introduce our moderator, Vern Mallow. I'm going to read a little bit about Vern. It's a very interesting biography. In addition to being a professional engineer and Ivy MBA, Vern holds a business development background that ranges from working with large multinational corporations to small medium enterprises. On 2 occasions as CEO, he led order of magnitude growth in manufacturing and robotics businesses, creating staff sizes of 100 plus and annual sales of $40 million. With offices in both Pelham and downtown St. Catharines, Vern founded Growth Associates and developed a leading business advisory service for Niagara business owners and executives. To date, it has delivered experienced and qualified support to over 150 owner managers and sparked breakthrough development for their enterprises. Past appointments include Director of Bosch Rexroth Canada, Executive Officer of CAE Industries, Transition Director of Niagara Region Economic Development Corporation, Economic Development Ambassador to both cities of Burlington and Welland, Committee Chair of NIA Government and Public Affairs, Vice Chair of Welland Development Commission, Executive Committee Board Member of Ivy Alumni Association, as well as past presidents of Welland Pelham Chamber, St. Catharines Ad and Sales Association, Canadian Foundry Association Suppliers Group, amongst others. And with that, I'd like to introduce Vern Mallow. Vern?
Well, thank you so much, Denise. That's way too long of a biography. I'm going to have to somehow shorten that. Sorry about that, everybody. I was blown away with the 3 panelists we have today. We were so lucky to have such qualified people to speak on such an important topic. I'm really looking forward to the next hour and hearing what these people have to say, because it's going to be very interesting. If the panelists could introduce themselves, let's start with Dr. Viljoen, if we may.
Good morning. My name is Johan Viljoen. I'm very much privileged to be here today, and especially on a panel with Dr. Hirji and Mr. MacIsaac. It's a true honor. I'm the Chief of Staff at Niagara Health, as well as the EV of Medical Affairs. So my privilege is to oversee the work of just around 600 physicians. We here in Niagara, as you know, provide 90% of all the healthcare that our community needs. And looking forward for us to discuss that today.
Thank you, Dr. Viljoen. Next, Rob MacIsaac.
Hi, good morning, everybody. As advertised, I'm Rob MacIsaac, and I'm the President and CEO of Hamilton Health Sciences. Hamilton Health Sciences is one of Ontario's largest and most comprehensive hospital networks. We have a dedicated team of approximately 15,000 staff and physicians working across our 5 hospitals. We provide specialty and regional programs across the full spectrum of care for adults, children. Our services include trauma, cancer, stroke, burns, and a number of other specialties. I think of particular interest is the fact that our network includes West Lincoln Memorial Hospital in Grimsby. So all told, depending on the service you're talking about, we take care of a region of about 2.5 million people across Hamilton, Niagara, Haldimand, Halton, Kitchener-Waterloo, and beyond. We do take care of lots of folks from Niagara, although Niagara Health, of course, is the primary provider of community health services, hospital services. But for a number of our programs, we also obviously look after folks in Niagara. We, just by way of example, Niagara residents on average would visit HHS emergency departments about 22,000 times per year. Some of those visits are to, our children's hospital for the pediatric ED, but, the lion's share of those would be at West Lincoln. I'm happy to talk more about all that's going on at West Lincoln. There's lots of exciting things happening there, but maybe I'll leave that for later on in my remarks. So maybe I would just finish by saying, we are a large system, but we can't do what we do without great partners. And Dr. Johan has been really a fabulous supporter, along with Lynn Guerrero and the entire NHS have helped us out so much in the last couple of years at Hamilton Health Sciences. We're really grateful for their partnership and for all that they've done to support us. So, Johan, thank you very much. We're in your debt.
Thank you, Mr. MacIsaac. And last, Dr. Hirji.
Thank you. So my name is Mr. Hirji. I'm the Acting Medical Officer of Health and Commissioner for Public Health and Emergency Services for Niagara Region. Very quickly to explain that, I think on the public health side, people are probably very familiar now with our work around infectious diseases and vaccination. But some of the other work we do is to investigate and follow up on health hazards. We oversee the health inspections of a range of types of premises, from restaurants to tattoo parlors, nail salons, swimming pools, etc. And then we do a lot of work dealing with, longer term health threats. So, trying to prevent chronic diseases, working on substance use issues, mental health, helping parents, children to get the best start in life so they set on a trajectory for good health over the long term. So really wide range of work that we do on the public health side. On the emergency services side, we of course oversee the emergency management system, our ambulance system that makes sure people who are in desperate need of help get care after a 911 call, and typically fall under the auspices of either Johan or Rob in their hospitals to get the definitive care that they need. We also, under emergency services, have the emergency management planning for Niagara Region under it, and of course that's been very busy over the course of the pandemic. And very pleased to be on this panel with two of our really important partners in both Niagara Health and Hamilton Health Sciences.
Thank you. Let's deep dive into our first topic. Of course, it's our post-pandemic era. Over the past few years, the majority of our healthcare focus has been around the pandemic. Surgeries, consultations, and public health programs have all been impacted. Can you describe for us the current state of healthcare and public health here in the region with regards to that topic? Shall we start with Rob MacIsaac?
Yeah, well, thanks, Vern. I guess probably the most appropriate opening line is the state of our healthcare system is not very good. If I'm just being frank, we have a system that is under an extraordinary amount of strain. We're facing challenges that are kind of haven't been seen in living memory. Many of those started before COVID, but they've really been exacerbated as a result of the pandemic. At HHS, and Johan will speak for NHS, I'm sure, but our sites are consistently seeing occupancy levels above 100%. I'm looking at my dashboard for this morning and see that West Lincoln is currently at 109% of occupancy. Juravinski would be a similar story. And if you look at the literature, and anybody who runs a manufacturing concern will understand this. Quality is a challenge as you exceed the capacity of the design capacity of the facility that you're operating. So I would say the literature suggests that ideally an acute hospital would be running at about 85% occupancy. That gives you some wiggle room for the inevitable, unforeseen occurrences. So when you're running at 110, 115%, there's no room for no margin, and it's really a crummy situation, frankly. We are not providing the kind of care that we would like to be able to. West Lincoln has recently seen occupancy as high as 120%. What are some of the factors driving this? Well, we're seeing alternate level of care levels. So these are patients who have been admitted for one reason or another, appropriately admitted, they've been treated, and their acute care journey has come to an end, but there is nowhere to receive them back into the community because of the state of their health. So, yep, they're not well, but they're not appropriate for staying in hospital, but there's nowhere for them to go. They can't go home, sometimes because there isn't appropriate home care for them. They can't go to long-term care because there are no beds available. There's 100 different, I'm being a little bit facetious, but there's many different reasons why. But the bottom line is, we are consistently seeing over 200 patients every day in our hospital who don't belong there, who would be much better off somewhere else, but there's nowhere else for them to go. This overcapacity of beds results in surgical backlogs. So the beds that would normally be reserved for people who are undergoing surgery are now occupied with either ALC patients, or they could be occupied with people who are still undergoing their acute care journey, but just because there's so many people, we're having to encroach on those spaces that would normally be reserved for surgical patients, which adds to our backlog of surgery. And beyond all of those things, we are seeing the most extraordinary challenge in health human resource. Again, I would say in living memory, we have thousands of jobs which are posted but unfilled. As of today, I think we're short about 775 nurses at Hamilton Health Sciences. We're also seeing sick time, which is higher than historical levels, in part because staff are getting sick with COVID and other illnesses and having to stay home. That's helping to drive our sick time. And then, of course, compounding all of this is we're seeing very significant increases in the levels of staff who are retiring. I think, that's in part because the baby boom is getting old. So you're seeing natural attrition because people are reaching retirement age, but we're also seeing lots of staff burnout as a result of the extraordinary hours they've had to work through the pandemic. We've said, I think it's just time for me to hang it up. It's a very challenging situation, and we are thinking lots about strategies to address these challenges, but there's no easy solutions. We're going to have to be creative, and I think all of us are going to have to be open to doing things in ways different from the past, because we will not get back to that past classic model of hospital care for a long, long time. And so we need to think about strategies to get us through this extraordinarily difficult period. Maybe I'll leave it there, Vern.
Okay, well, thanks, Rob. That's a lovely, honest perspective, and certainly one that we all share. Dr. Hirji, who would you care to comment?
Sure. I'll maybe go back to something you said, Vern. You used the phrase post-pandemic era in introducing this question. And, I think actually that's a bit of a misnomer, because the pandemic isn't over. I think we're absolutely past the worst of the pandemic, and it's clearly a much better point. We're not dealing with the same kind of restrictions that were going on before, but it's not over. And I think a lot of the struggle that we're feeling in public health and my friends are feeling in the healthcare system is actually a reflection of that. COVID-19 has kind of settled into being the third leading cause of death in Canada. So everybody's still suffering from all the other illnesses that they were, and we've just tacked on one more thing. So when you think about, what our hospitals have to go through, they're still dealing with all of the old illnesses, and they've been suddenly foisted on this, one additional major one that I have to deal with. And so that's obviously a huge pressure on them. As I think Rob has very, eloquently described the staffing challenge that they've had in terms of burnout, in terms of people being off sick. We've actually seen, several economic reports saying that this is true across our economy, where people with both short-term and long-term illness has gone up, which is impacting the workforce supply that we have. And then because, the hospitals are dealing with COVID, we in public health are dealing with COVID, our long-term care homes are dealing with COVID, we're all trying to hire up additional staff, which is feeding into that whole staffing crunch that we're dealing with, because there's more people trying to hire more staff, but that pool of staff is at best equal and perhaps shrinking a little bit because of more people, leaving the workforce due to burnout, approaching retirement and the like. And so I think that's, really a crux of what we're dealing with here. Just to expound a little bit on what that means in terms of public health a little bit with the pandemic not being over. So we are still managing outbreaks. We have 20 outbreaks on the go right now in long-term care homes, retirement homes, and hospitals. While most people can't get a PCR test, there's still about 400 or 500 people a week who are testing positive with PCR tests in Niagara, and that requires us to do individual follow-up with them, so we're very active doing that. About 200 members of the public give us a phone call every week to ask questions around COVID-19, so we're still handling that. We're still doing vaccinations. We do about 1,000 vaccinations within public health a week, particularly trying to focus on communities that have barriers to accessing vaccination and really focusing on those. And then, of course, our friends in pharmacy are doing a huge number additional to that amongst people who don't have barriers and have equal access to pharmacies. And then, we have lots of health inspection work that's still going. When there's been an exposure to COVID-19, we are doing visits and we're trying to do some proactive work. So I talked about how we inspect restaurants and we inspect pools and we inspect nail salons, etc. When we're going out to those inspections, we're also trying to educate the operators on some of the things that lead to COVID-19 spreading, particularly around ventilation, having good air handling systems, and trying to give them the education and advice so that they can try to make those premises safer, which is additional burden on us because we're doing a little bit more than we would normally in terms of our normal inspections. So, lots of work dealing with a pandemic there. Just want to quickly talk about, though, because, the last 2.5 years we were dealing with a pandemic, a lot of our staff were redeployed from their normal programs to doing pandemic work. So just like actually our hospitals, I'm sure Viljoen will just talk about in a moment, we have a lot of backlog of things that we need to do. Particularly notable for us is vaccinations among school children. Schools were both closed for long periods of time, so we weren't able to go in there and do vaccination, and we often didn't have the staff to do it because those staff were busy managing COVID-19. So we have a huge push this year to try and get school children caught up on their vaccinations so we don't start to see reemergence of other diseases. I think everybody heard recently that we had polio popping back up in the United States, in the United Kingdom, in Israel. And that's partly a reflection that vaccination coverage has slipped, and we want to make sure that we get on top of that here as quickly as possible. Other things like dental screening have fallen behind. There's lots of young families who are high risk, who are in difficult circumstances that we weren't able to provide follow-up with. And so we really want to be, catching up with giving them the support that we need. And then there's an area of, also health where there's some lost ground because we weren't as active in the last couple of years. I'm thinking particularly about opioid overdoses, where we're really, starting to do more and more on that topic. And the pandemic kind of pushed us back 2 years where we didn't really have that same level of focus. Additionally, things like chronic disease, mental health, people staying home, all of the challenges of the pandemic have probably worsened those to some extent. And so we really need to make sure we're re-engaging in that work and helping people out. Just a couple of, higher level than organizational comments I just want to make that, as we're getting our public health programs back up and running, a strategic goal for us has been that we don't just get them back up and running the way they were in 2019, but that we get them back up and running, but we take this opportunity when things weren't running, that we restart them by rethinking how we deliver them to hopefully, adopt them and adapt them to ways that, some of the lessons we learned over the pandemic. So much more virtual work and delivery, which I think we'll come to in a future question. And then the other big strategic goal we have right now is staff engagement. We're talking about staffing challenges. So the more we can support our staff and fight off that burnout, the more we can keep them engaged so they stay loyal to us as an employer. That is really key. As well, recognizing we're going into a period where COVID-19 is going to surge again. Our staff are going to be stressed again. And we want to make sure that they're well supported, that they're going to be able to support our population as best they can during this period.
So true. Thank you so much. Dr. Viljoen.
Thank you very much. Listening to Rob and Mustafa, certainly I agree with everything they've said. the pandemic has taught us a lot. So if you quickly look back over the last 3 years, first we were fighting to get a vaccine, which we did. We rolled it out very successfully. Then we struggled to keep people in our ICUs alive. And I would argue that without an immense across-system cooperation, the picture today, if you ask what's the state of healthcare today, could have been much worse. And I would say that as a sub-region of Ontario Health, here in Ontario Health West, we have done a remarkable job in supporting each other. And I would really want to see that continue. That should be the continuing norm of working with each other, supporting each other, always being well connected. So that's the one big benefit we got from the pandemic. So my glass is half full. And as we are here moving into a different phase of the pandemic, and I cannot agree more with Dr. Hirji, this is not over. And it would be foolhardy to think it is over and to act and live as if it is. We still need to be vigilant, because that will help us catch up with everything that everybody has said here. There are lots of people waiting for a hip, a knee. There are people waiting for breast cancer screening, which is essential. I mean, these are just a few things I can pull out of the maze of things that we have to catch up with. And all while this is needing to be done, we have to keep healthcare systems running, and we have to keep innovating. Healthcare does not stand still. So we have to continue innovating. Here at Niagara Health, we've got a fantastic future ahead of us. We're going to build and implement a new HIS over the next 2 years, a hospital information system. Rob has just completed that job in his system. Hopefully in the spring of next year, we're going to have shovels in the ground in Niagara Falls for a 469-bed hospital, which when completed will give us 156 net new beds for Niagara. As an outflow from the pandemic, this hospital is going to have 100% of its rooms single occupancy. So just think how much easier, if we ever have to manage something like this again, that might be. So there's a lot of positive coming out of where we are at the moment as well. Health human resources, huge issue for us. We have 600 vacancies in our nursing staff and allied staff that we are recruiting for. Amongst physicians, we have the same issues as Rob has in his system. There are specific specialties where we are really struggling at the moment. One is anesthesia. The reason why I bring out anesthesia is if you don't have enough anesthetists, then that's going to affect your surgery. So it has a domino effect that you have to deal with if you lose people from certain specific specialties. And that is certainly something we are coping with at the moment as well. But I'm positive. We as a system will keep growing. We will keep innovating, and we will keep doing everything we can to keep our doors open. We are very proud at Niagara that through the course of the pandemic, we've had only 2 instances where we had to very temporarily close services in an urgent care center. And we work full out to prevent that on a day-by-day basis. So yes, it's tough. It's a tough time at the moment. Yes, we need people, but yes, we are also looking to the future at innovating, at building, and at making what we have better for our community.
Oh, thank you so much. It begs the question: have we lost press momentum at this point? And with that, can we look back retrospectively and say that one of the skills that we've had to learn as medical officers is one of media communications, and not something that we had to really take that seriously in the past. You look at certain segments, be it socioeconomic or whatever, that we're not viewing, the crisis as it was, and so on and so forth. Would anybody care to comment on that and whether it was an issue or did it come to a reality at some point?
I can maybe say a few things to begin. I think you've highlighted that physicians like us, healthcare people, were much more in the news over the last 2.5 years than ever before. I think we've all had experience doing media, so I don't think we were terrible at it. But of course, someone who is trained, and this is the job that they do all the time, is going to be better at that. And I think there's lots of things that we learned over the course of the last couple of years to start to hone that message a little bit more, but there's certainly more we can do. One of the big challenges, I think, has been that the media landscape, the communications landscape has just changed so much, especially with social media and some of those actors that we see on social media. We know that there's foreign actors out there trying to cause mischief. We have other actors out there trying to spread misinformation. And really combating that misinformation has been a real challenge. And I don't think that's really something exclusive to us in health. I think we're seeing in politics, we're seeing in many different walks of life where misinformation has really taken on a strength that we've never seen before, and trying to, have a society that stays oriented around a set of facts that we can all agree on are true, and then we debate from there how we should respond, has become really challenging across a whole walk of life. And I think we, as long as with the rest of society, really needs to learn a little bit more of that. The one other thing I'll just quickly say around communications, I think one of the challenges we've had through the pandemic has been when not everybody has been aligned to the same message. And I think when we are aligned to the same message, I think particularly back in March of 2020, when the pandemic first launched, I think everybody was unified as a voice. And I think that really made it clear to the public of how we should respond. And we really had the trust and buy-in of them. And I think as we've lost some of that unity of message and not everybody is necessarily on the same page and giving the same message, I think it's, at the very least made it more confusing for the public of how they should respond, but perhaps also harm some of the trust of the public of which message is right, in the sense that, if they can't agree on what the message is, who knows what's right, and I'm going to do what I just want to do.
Thank you. Any other comments from others? No?
I just like to add the value I found out in transparency. Be transparent. Give people accurate data. Trust, as Mustafa said, is extremely important. It was a time of severe uncertainty, not knowing exactly where this was going to go, not knowing much about the virus. And all those other external actors really made life difficult because everybody became an expert overnight. So transparency, accuracy with the data that you share, and frequently so. So keep good and constant touch with our community was very important.
The only thing I would add, Johan was sort of thinking about silver linings to the pandemic. I think one silver lining, at least for us, was, if I turn my mind to our internal audiences as opposed to those external audiences, we definitely had to amp up our communication strategy with our own staff and workers here at Hamilton Health Sciences, because they were working under extraordinarily challenging circumstances and needed to know where the organization was at and why we were doing what we were doing. And so I think having very frank, open, as Johan said, transparent discussions on a very frequent basis with our own teams was a requirement to help us get through this challenging time.
It probably leads us into the next question. We have been hearing a lot about virtual healthcare, HIS, and so forth. What does this mean, and how will it be incorporated within our respective organizations? How will it change the patient care experience within the health system? Will it impact public health programming? Shall we start with Dr. Hirji on this one?
Sure. So, in public health, we do more preventive work, and often we're working with a large group of people rather than individuals. So I think it's going to be a little different for us as compared to some of my colleagues here. I think one of the silver linings of the pandemic is that we had to shift so much of our work virtual that we actually learned how to do a lot of that. To some extent, we've always done a little bit of virtual work. I think, for example, around tuberculosis, when someone has been diagnosed with tuberculosis, standard of care according to the World Health Organization is we do something called directly observed therapy, where because people have to be on 6 to 9 months of treatment, and if they don't take their treatment, you start to get these drug-resistant versions of TB emerge. they actually want public health providers to actually watch people taking their meds 3 times a week to make sure that it's being done correctly and that they're regularly taking their medications. So in the most basic form, you're visiting the patient who is being treated for TB, watching them take their meds each time, making a record of that. We figured out a long time ago that that wasn't really the most efficient use for someone to drive out there to spend 2 minutes watching someone take medications. So we really shifted into the pattern that we would, start off with the in-person visits early on, because early on, someone is newly diagnosed with TB, they have lots of questions, they're struggling with this, and being there in person, being able to give them the support, answer all their questions is really valuable. But after a couple of weeks, they've got into a pattern, they're, feeling comfortable with this. We don't need to actually be there. And so we started to introduce virtual ways of connecting, particularly with younger people who are more tech savvy. We connect with them on WhatsApp or Skype, and they do a video conference, and we watch them take the medication that way. And that way it's much more efficient on us. It's probably more convenient for those individuals as well, that they didn't even have to clean up their house to let someone in. And it made sure that we are still meeting what was expected by the World Health Organization. I think that's kind of the pattern that we're going to take here in public health, where there's something that comes from that in-person interaction that you just can never have with a virtual interaction. But the virtual interaction is really efficient. In some cases, that may actually be all you need. You don't need to have that more detail. So I'm thinking, for example, around high-risk families who are living with many social struggles. And we do have a home visiting program funded by the province, where we are visiting them, providing support to the parents, providing support to the children, helping the parents adapt to having a young child and taking care of them. And we would do that in person. With the pandemic, we started to do a lot of that virtually. We're seeing the future of this as actually being a bit of a hybrid, where we're going to do some in-person visits, because there's nothing like being in the home of a person, really seeing their living situation, really understanding what they're going through and what their challenges are, but also recognizing that sometimes you just need a quick touch base. You're not necessarily going to be doing that full assessment, so you don't necessarily need to be in the home, and you can do a virtual appointment, which may actually be more convenient for everybody else. So that's the kind of pattern I think we're going to be going down the road of, really trying to introduce virtual work into how we deliver programs. So we have the best of the in-person visits, but the best of the virtual visits, and we actually improve the experience of their patients they're serving, while also hopefully being a little bit more efficient. Other places where it's really obvious we can do virtual work is in terms of classes. So we do, food handler certification classes. We're moving that to being virtual, I think, over the long term. Some of the classes that we do around parenting or prenatal classes will have some in-person options, some virtual options to really meet the needs of everybody out there. And then quickly just speaking about emergency medical services or ambulance services. One of the things we found with ambulance services is that probably on the order of about 90% of our calls aren't necessarily something that are truly life-threatening emergent in that level, that it's not something where someone needs to be rushed to the hospital right that instant. It's not going to necessarily improve their care. And actually, if they show up in the hospital in that state because the hospital realizes that, yeah, this isn't that serious, we have a few more patients who are more serious, that person's probably going to end up waiting several hours before they get care. So what we've done is actually we've put nurses into the dispatch center. When you call 911, you go through that initial triage with the what's called the system status controller. They're the trained, health professional who does that. And if they realize that you're lower acuity, one of the different options we'll have is we'll actually have them referred onto that nurse to have a follow-up conversation with them and to try to give them some of the care over the phone that they need, so that maybe they don't actually need to have an ambulance come and need to go to the hospital, which of course lessens the pressure on our ambulance system. It lessens the pressure on the hospital system, and it actually maybe gets a person the care that they need immediately over the phone. And so that's another way we're trying to introduce some more virtual care into how we deliver our services, even in an ambulance service, which traditionally you wouldn't think of providing that kind of service.
Dr. Viljoen?
To me, if you look at virtual healthcare, it means everything that does not require touch. So not everything in medicine is amenable to virtual healthcare, but a lot is. It's also not as new as we think. Our colleagues in mental health and addictions have probably been doing this for 2 decades, if not longer, and have a lot of experience in it. And within the clinical realm, there are certain specialties that are going to be more amenable to being done virtually than others, of course. However, it is definitively the wave of the future. There's no doubt about that. And if you have a sophisticated digital platform like HHS already has and that we will have soon. It does enable you to do things much better, much more smoothly, and it helps with the confidentiality and the cybersecurity, because when you're on a virtual platform, you're dealing with patients and their personal health information, and you need to know that that is secure. So all of those things will be developed. We have to be mindful, however, that we do not lose the human touch, because there are certain things where if you and I make eyeball to eyeball contact in a room, it is just so much more fruitful. When we develop these virtual programs, we must be mindful as to how we construct and build them. One of the big advantages I see, especially for an area like the Niagara region, it's a vast region. And there are a lot of people who live in small communities far away from a hospital. And it's really not great for them, especially because we don't have fantastic public transit, to come to a hospital for a quick 5-minute visit with a physician. And this is where we need to partner with larger telecom companies, that we can bring affordable, easy to use devices of all sorts into the homes of people, and especially our elderly people, because we can really make a difference. So virtual healthcare, it's easily spoken as a phrase, but there's great possibility if developed carefully and brought into the hands of people at an affordable price.
Wonderful. Rob, we've heard HSS's virtual platform mentioned a couple of times already this morning. Could you tell us a little bit more about what it is specifically and what might be coming to Niagara as a result?
So first of all, maybe I'll just say I think both Dr. Hirji and Dr. Viljoen's remarks were really thoughtful, and I agree with what they said. For us at HHS, we've definitely scaled up virtual care. Since March of 2020, we've had almost 750,000 virtual patient visits or appointments at HHS. And some, beyond sort of the obvious impacts, we've noticed that, our rate of no-shows for these virtual appointments is about 50% lower. So, in an ambulatory setting right now for us, about 30% of our ambulatory, in other words, are the patients who've gone home, who are coming back for whatever reason to see their surgeon or their physician. About 30% of those are now taking place over the internet as opposed to in person. And of that 30%, we've got 50% better attendance, because sometimes people just skip their appointments, which is a horrible waste of resource for everybody. We're also using virtual care in a way to try to reduce the number of the length of stay for our hospital patients. So we have a number of surgical procedures now where we will send patients home sooner than we otherwise would have. We will monitor their condition remotely, so we can monitor vital signs. We can have the patients take pictures of their wound sites, for example, and send them in so that we can monitor the rate of healing for their wounds. So, that program has been very effective at us to free up these desperately needed beds to allow others to come in to have their surgeries done. We did in June go live with our new hospital information system that Johan referred to. It's the software is called Epic, probably the largest project, most expensive project that Hamilton Health Sciences has ever undertaken, and really ultimately transforms the way that you do every single thing in the hospital, because everything, you're essentially moving to a paper-free environment. And when you think about what that means for the way in which you operate, you essentially have to look at every single process that takes place in your hospital and redesign it in a way that's amenable to being paperless and working through this new computer system. So you're essentially starting from scratch and redesigning how it is that you operate your hospital, which is, part of the reason why it's an extraordinary amount of work, and it's an extraordinary amount of change. But it also comes with a big payback. Some of the practical things that we will see as a result of this from a patient point of view. Patients will be able to book and attend virtual appointments with their providers in a way that they never did before. We'll have, secure video platforms. In many respects, this system really empowers patients in a way that they never, with abilities that they never had before. Yes, they can now start to control exactly when their appointments are. When they're in hospital, they can go on the patient portal and see, here are my test results. Here are, I see I'm scheduled to have a CT tomorrow morning. And the porters are on their way. And here are all the prescriptions that I'm taking while I'm here at the hospital. So it gives you a kind of, as a patient, it gives you insight into exactly what's going on with your care in a way that was never previously done. And, that can be a little unnerving for the providers of the care who are used to sort of being the keepers of the vault. But it essentially really opens up the vault and allows patients to see exactly what's going on. You can look at your own chart. You can see the medications that you're on. You can see the tests that have been ordered, the test results as they come back. And this applies not just to inpatients, but of course, through that portal, if you're an outpatient at HHS, you can similarly go in and look at your chart and see what's going on with your case. So it's a massive transformation for us, and I think ultimately we'll see lots of new efficiencies, lots fewer hospital harms, things like medication errors, and on and on and on will occur far less than they ever have in the past. And patients will be empowered in a way that they never were before.
Wow, that's really interesting. I really never thought that HIS took that much into within its scope. It's basically an enterprise software for hospitals, isn't it? Wow, that's amazing. And I can't believe staff, in this era of the pandemic and everything else that's gone on, are able to actually implement that, because that's a big shock to any organization to take that on. Congratulations. Yeah. Not easy.
I think so. It was a project that was years in the planning. If we had known that we were going to go live in the middle of a pandemic, it probably would have given us some pause. But it's, once you start down that road, it's for us to have abandoned the project in the middle, in mid-stride would have been disastrous. Yeah. So we had to push on.
Wow, that's amazing. That's amazing, and great news. Absolutely great news. I'll move on to the next question. What would you say is the biggest challenge or challenges facing your organization, and what strategies are you developing to address them? Certainly even a future wave of our pandemic and whatever else and so forth. And you have already addressed many of these things, but what do you see as your top priorities? Dr. Viljoen, would you like to start on that?
Sure. If you have a challenge, you need a plan. And just because we were not busy enough at Niagara Health, we are working on a new strategic plan that we're going to launch early in the new year. And as we worked up towards structuring this plan, we reached out to our teams, physicians, nurses, allied health, everyone, because we realized the vast importance of retention. Recruitment of new staff is already difficult as it is, and we realize the need to focus on looking after those who are with us currently. So we have really taken the ideas and challenge that they have pointed out to us, and that will be built into a strategic plan going forward over the next number of years. So certainly the challenge there is recruitment, retention, and competition with others for staff. We will continue to see pressures on our EDs, as Dr. Hirji said. November, December, January is the big unknown. We don't know where that's going to take us. But the other big challenge for me is to get our community and ourselves to reset slightly what we see healthcare to be. Healthcare is not just what happens in the acute care setting. That is but a moment in the continuum of care. And we have to really reinvigorate engagement with the community. And that community is the people of Niagara and the primary care, healthcare presence in Niagara. Because as an acute care system alone, this is not a road we can continue walking. We all have to reset and understand the contribution we all make to our own healthcare and that the community does. So that to me is a very pressing challenge, is to get everyone to understand that yes, we the acute care health system are there for you when you need us for the acute episodes in your life. But for everything else, we're going to have to stand together. So the entire concept of the Ontario Health Team, and here in Niagara, we have 47 partner organizations. Can you imagine if we leveraged all of that appropriately, how much better the delivery of healthcare can be? So that, I think, is a definitive challenge for us to take on.
Rob, would you care to comment on your challenges?
Well, I think the biggest challenge is clearly the shortage of health human resource. And as I was saying earlier, we are going to have to think differently about how we provide care because this is a huge rate limiting factor. If we decide that the current models of care, ways of doing things have to remain. So, just in broad terms, we're trying to get better at recruitment. So we had a decentralized recruitment function at Hamilton Health Sciences, which we have now centralized. And I think that allows us to be more strategic in pursuing recruitment opportunities across the province. We are amping up our efforts to attract foreign trained medical or healthcare allied health professionals. So, increasingly we're seeing an international competition for healthcare workers, and countries around the world are doing this, and we have to be really good at it, both as individual institutions, but also nationally. So, that is a definite area of focus for us. We have to look at different models of care. So how is it that we do things within our walls? And I think we're thinking definitely about the notion of creating new roles within the hospital, which will expand the available pool of labor. And relying more on people who are trained narrowly but deeply in very specific areas in a way to free people, other credentialed people to operate at the top of their practice. So that you shouldn't have a registered nurse doing things that somebody else could do. They're highly trained, expert, highly able people, and if you have them change, just to say something that's absurd, but if they're changing beds or doing other things like that is such a waste of a registered nurse's time. So we have to make sure that for the staff that we have, that they're practicing at absolutely the top level of what it is they're allowed to do. I think, we have to think about retention. So in addition to attraction, it would be crazy if you were not thinking about how can we keep the great people that we already have here. I think in part that's about thinking about the working conditions that we're providing for our staff and making sure that we're doing all that we can to get them out of the work that they hate doing and allowing them to do the work that they love doing. And I think, so there's an automation play to that. Nobody likes doing, data entry into computers. People want to be at the bedside, providing care to people. How can we make sure that we're allowing people to do that to the maximum extent possible? Also, I think, it's important to note that, a 25-year registered nurse is a lot different than a first year or second year registered nurse. So I think we need to be thinking about creating very specific new roles for our most senior staff that gets them out of sort of the heavy lifting and makes sure that we're taking advantage of them for, the wisdom that they've acquired over 25 years. And not thinking that if they leave, they can be easily replaced by someone just coming out of nursing school. Those are some of the things we're thinking about. It's not a comprehensive list, but those are some of the broad strategies that we're working on to try to deal with this very critical shortage of people.
Wow, it's a whole new makeup. Dr. Hirji?
Yeah, I think we've talked about a few challenges already in terms of the pandemic, staffing. The one I'm going to focus right now on is, I think, the budget and funding of public health. So since 2015, we've actually had basically a freeze in new funding in public health. So every year we get the exact same money as previous, despite there's being inflation and the like. Did get a small increase in 2018 and 2022, both times as part of basically a pre-election budget. But, the 1% increase in funding that we got in 2022 obviously doesn't come anywhere near meeting inflation, and certainly doesn't make up of, the previous years where we've had no additional funding. And so we actually managed in the years prior to the pandemic that every year we were laying off staff in public health to stay within our provincial funding envelope. During the pandemic, the province hasn't increased our base funding, though they have been quite generous in terms of one-time funding for COVID-19 prevention measures. And so that's really given us a way to patch over our budget situation over the last couple of years. But this is all one-time funding when we're, competing with the rest of the health system to secure staff. That's not really allowing us to have permanent positions. And so we're not really able to retain staff very effectively with that. As well, we've talked about COVID-19 has settled into the number 3 cause of death in Canada. It's a major health issue going forward. We're going to need to keep managing this forward. So we need to have some recognition of what is our ongoing funding now on a permanent basis for managing COVID-19, assuming we stay on the current strategy that the province is on. And I talked a little bit earlier about how we need to catch up on childhood vaccinations, on dental screening and support of families and the like. And we don't actually have any funding for that additional catch-up work. And so we really need some funding for that. So we're really dealing with an unsustainable budget, becoming more unsustainable given how high inflation is, with no real funding that's permanently promised for ongoing COVID-19 work or for the catch-up work that we need to do right now. In terms of ways to solve this, we're trying to do our best in terms of creative budgeting. We as local public health agencies across the province are actively lobbying the province and trying to make sure that they hear about this and the importance of funding. But one other thing we're going to have to do is be really transparent with regional council about what the situation is, because I think it's ultimately turning into a choice for them. Do they step in to make up their costs that aren't being funded by the province, or are they not going to, and we're going to have major service reductions? And I think council should be really mindful that this is effectively a downloading of costs onto the local level. And I, would like them to be really engaged. And I think they've been to some extent engaging with the Association of Municipalities of Ontario, other groups to really, push the province hard that they need to step up and deliver the funding so our public health service can be sustainable. And I think we've hopefully recognized the last 2.5 years how important it is to have a good public health system. And I hope that we can come out of this with a more sustainable funding approach for public health so that we can be sustainable in the future.
Oh, thank you. Final thoughts. Anybody have any final thoughts? Should we start with Rob? What would, based on our discussion here, what have we missed?
I think the message I'd like to leave the group with is that we are dealing with a system that's under an extraordinary amount of pressure. And I think in broad terms, Winston Churchill said, never waste a good crisis, or words to that effect. I think we need to take the current situation as an opportunity for all of us to have an honest discussion about the state of our healthcare system and the need for change within the system. If we continue to eviscerate everybody who talks about changing the system, we will be stuck with the system that we have. And frankly, if we look at how I don't want to be overly critical, but the truth of the matter is, if we look at how our system is ranked internationally across an array of quality metrics, we are not at the top of the class when it comes to the developed world. In fact, our healthcare system is very much closer to the bottom of the class. And so, yes, there's lots to be proud of in our healthcare system, not least of which are these unbelievable workers who have helped us get through the last couple of years. But you can't run a healthcare system on heroics. We need to have a system that's sustainable. And that is not where we are currently at. And in order to get there, we have to be open to new ways of doing things and start to have a real discussion about how healthcare is provided in our community. So that would be my admonishment to the group. Thanks, Vern.
Oh, thank you. Dr. Hirji?
Yeah, I'd really highlight that I think the pandemic isn't over and we need to bring it to an end to relieve a lot of the challenges that we've talked about today. Short term, we have new booster doses out. If you're age 12 and up, make sure you go out and get your booster dose. It doesn't matter how many doses of the COVID-19 vaccine you might have had prior to this fall. If you're age 12 and up, you can get one more booster dose this fall, so go get it. Likewise, flu shots are rolling out to everybody starting next week. Make sure you go get it. The more we're protected from flu, the less we're going to be a pressure on the healthcare system and others. And I'd really recommend we all wear masks indoors and in crowds as well, especially as we go through the next few months, which will be challenging. But I think the long-term improvement here is to actually take the big lesson that I've taken away from the pandemic, and I think many of us has, is that this is a virus that probably like influenza, like colds and others, actually spreads through the air. It's a different way of thinking about this virus. And so because it spreads through the air, there are things that we can do to improve that. We can improve our ventilation systems in buildings where we have lots of members of the public. So we're bringing in clean indoor air and getting rid of air from the indoors that might have some virus in it. We can have better filters. We can have UV disinfection systems in our air circulating systems to make sure we're disinfecting the air, removing the virus, which makes everything safer. And I think if we do that, we can not only bring COVID-19 to a much lower level, but influenzas, colds, all of these other respiratory infections that spread the same way, we can actually bring them down as well. Influenzas and pneumonias are our number 8 cause of death in Canada. What if we could bring that down? And there's an opportunity that we could come out of this, not just actually being as healthy as we were before, but maybe we've actually reduced other health issues. So we're more healthy as a society. We know people who are marginalized, lower income, minority race are more disproportionately impacted by all these illnesses. So we could be a more equal society by bringing them under control. If people are less likely getting sick, they're less likely off work, or they're less likely staying home to take care of their kids who are sick, we're more productive and we're more prosperous as an economy. And of course, all the healthcare challenges that we're dealing with that are in part fueled by COVID-19 can be lessened so we can have a more sustainable healthcare system. So I really think there's an opportunity for us as a society, if we make the right investments now, to become more healthy, more equal, more prosperous with a more sustainable healthcare system.
Great, thank you. And finally, Dr. Viljoen.
Thank you very much. Just have to agree with everything that has been said. I think in summary, I would say where we find ourselves today is a very ripe time to to bring change. Everybody is sick and tired of what we have around us at the moment. This is when people are the most receptive for change. So it's time to think differently about healthcare. How we've been thinking up to now obviously is not working, hence we are where we are. So let's think differently now. To Rob's point, different models of care, different places of where you find what level of care, and get the community involved. They are as much a part of the solution as the acute care system is.
Our time is up, and you know, I'd certainly like to very much thank our panelists. What a lovely level of discussion we've had, and one that I think all of Niagara needs to hear. And so thank you so much for your time and for your insight. Certainly, it was insightful for me, and I'm sure everybody else. There are lots of things we're picking up from this discussion, and very enlightening. So thank you for your time, everyone. Just want to mention very quickly, next week's session is on the topic of best practices for recruiting and retaining talent. Certainly one was even brought up quite a few times today. Our panelists will include Michelle DeLuca, who is Senior Human HR Consultant at Durwood Jones Barkwell, Marina Butler, who is President of Employment Professionals Canada, and Kevin Verhoff, who's owner of Verhoff Electric. So that's on, I believe, probably same time next week. So join us for that. And again, thank you so much to our panelists for your valuable time and wonderful insight. Appreciate it. All the best and have a great day, everybody.